So welcome everyone. We're actually going to start off this part of the presentation with a case. And that case is a 55-year-old male presenting to your emergency department. He's with his wife. He presents because he started to feel dizzy 3 hours before he went in. Shortly after arriving into hospital, he became unresponsive in triage. This was briefly followed by an LVAD alarm. You're left with an unresponsive LVAD patient, and that's the focus of today's talk, is how do you approach this in a non-VAD environment. And I'll briefly just review the algorithm here, and then we'll take a deeper dive into each of these. So you want to start off by determining if the VAD's functioning. If it's not functioning, you really just treat this patient like a normal VADless patient. Check if they have a pulse. If they don't have a pulse, you start traditional ACLS. If they do have a pulse, then you want to look for non-cardiac causes. The VAD is functioning, and that takes you in a different part of the algorithm. Similarly, though, you're going to check if the patient's perfused. If they're not perfused, then you start ACLS. If they are perfused, then you want to look for non-cardiac cause. So let's take a deeper dive into each of these. How do you actually determine if the VAD is functioning? And really, we've wanted to leave this just simplified at this point. You're going to auscultate for hum of the VAD. If there is a hum, the VAD is working. If there's no hum, the VAD's not working. This is going to be part of your primary survey of the patient as you're quickly assessing what's going on. You might get some other sort of obvious clues as to why the patient's presenting the way that they do. So if the VAD isn't functioning, that takes you down the top part of this algorithm. So that's why it's really key, because it branches you off into two very different points. And if the VAD isn't working, the malfunction may be the cause, but they could also be unresponsive for other reasons. So it's important to approach this as just a normal patient. And you're going to want to check for a pulse. If they don't have a pulse, then you just go into standard ACLS. And we'll take a closer look at that. We've sort of lumped this as normal ACLS, but you go through your H's and T's and V's, so your VAD specific considerations. And this part of this you really want to assess sort of a basic overview of the VAD. Has the power become disconnected? Are the batteries out? Is there a controller malfunction? If a family member is there, you may be able to have them help you switch in a new controller. They should all have a backup controller with them, and hopefully that's been brought in. Finally, the driveline may be injured in a way that you can't repair the pump. Maybe they had trauma to it or just a repetitive stress fracture. So these are all things that you can quickly sort of assess and determine. Some of them may be an easy fix, some of them may be less easy. Driveline failure you're not going to be able to fix, and you're going to be left with a VAD that doesn't work. You also want to consider pump thrombosis here. This is a tricky one to determine what to do with, but hypothetically, the pump that's been stopped, when you restarted it, may have a risk of thrombosis. Locally, we would give a bolus of 5,000 units of heparin for this, but there's no clear guidance on what to do here. And then finally, you want to consider VA ECMO. If you have a non-working pump and someone who's arresting because of that, and your center is capable of VA ECMO, you want to be preparing to do that. So we look at non-cardiac causes. These are your standard things, that you would think in a normal patient: stroke, hypoglycemia, respiratory failure, or toxidrome. But importantly, what you want to consider here is that the VAD's not working for some reason, and this could be related. Maybe the VAD's thrombosed and they've had a subsequent stroke. So you don't want to forget that, and you want to loop in. You have time because your patient's hemodynamically stable, so you want to contact the VAD's center to troubleshoot this. You also want to pay attention to that issue we talked about of a thrombosed VAD that's not working. Here, if they're stable, you probably don't want to turn that VAD on until you've reached out to the VAD center. And I would do that immediately and sort of work with them as the best solution to this problem that probably has no good solution. All right, so let's go back to the algorithm. And in our patient's case, they actually had a bad hum. So that really takes us down the lower part of this algorithm, which we'll explore in a little bit more detail. Just like in a normal patient where you're checking if they have a pulse to see if they're perfused, you want to determine if the bad patient is perfused. So we'll take a closer look at how you can do that. And the gold standard is really measuring their map using a Doppler ultrasound. So you get a manual cuff, and you take your Doppler, you put it on the brachial artery, you inflate that cuff until it goes away. You start to deflate it, and when you hear arterial pulsation again, that is your map. If it's above 50, the patient is perfused. If it's less than 50, they're not perfused. So you consider that just like you don't have a pulse. In alternative, if your patient happened to be intubated by the time you're getting to them, the AHA guidelines actually specify that if you have an end tidal CO2 of greater than 20 millimeters of mercury, you are likely maintaining an adequate cardiac output. And you can combine this with other signs of adequate perfusion. Are they pink? Do they have good cap refill? And importantly, this isn't an intubated patient. You can get spurious measurements of CO2 with an LMA in or for other reasons. That one final note here is just about the VAD, what's the VAD flow meter, the calculation that it does and spits out a number on the controller. This may not be a reliable measure of perfusion. It's calculated artificially. It doesn't actually measure flow. What it does measure is power consumption and RPMs and a few other variables that are inputted by the operator, like hematocrit, and it uses those to estimate a flow. So that's okay in a normally functioning VAD, but consider, say, a VAD that's thrombosed. The impeller will have a harder time spinning, and therefore it will draw more power, and therefore the VAD flow meter will read a higher flow when in fact the flow is reduced. The only reason it's spitting out a big number is because it's consuming lots of power to try to spin through this stew of clot. So if it's high, it may not be indicative of high flow. If it's low, that's probably actually accurate and you do have a low flow. The point being, don't rely on that. You need to rely on actually measuring the map yourself. SAT probes may not read because of the lack of pulsatile flow. If you have a good tracing and a normal SAT, that's probably accurate. It's just hard to get one of those. Similarly with a blood pressure, automated blood pressure, if you actually get a normalish looking blood pressure, that's probably accurate, but it's not a reliable way to measure these things. So if you're not perfused or you question whether the patient's perfused, just start ACLS. Again, just do regular ACLS. It's okay to do chest compressions in this patient. And so just like in the non-perfuse or in the non-working VAD algorithm, you've got your H's and T's, and we've added in V's here of VAD specific considerations. And it's important to know that the pump flow is dependent on preload, afterload, and native contractility. So things you want to consider are in those contexts are preload. Bleeding's common, hypovolemia can lead to arrest. You can have your usual correctable things, tamponade, tension pneumothorax. RV failure is less immediately correctable, but failure of the RV will lead to dilatation of the RV, which impinges LV cavity size, and also you just won't be pumping volume into the LV, so the VAD can fail in that way. Similarly, hypoxia, hypercarbia will lead to lack of preload in the LV and could also lead to RV failure. Afterload is an interesting thing to consider. Your usual things that lead to a drop in SVR, like sepsis or anaphylaxis, your normal body has ways to compensate for this. Your heart rate goes up, stroke volume increases, those sorts of things. But the VAD does adapt to changes in loading conditions to a small degree, but not enough to compensate for these big changes in SVR. So someone who's in septic shock may manifest in a much more severe way because the VAD can't um, increase cardiac output adequately. It relies on somebody push changing the RPMs up or down. So if nobody changes those RPMs, your cardiac output will stay at what it was at for normal physiologic conditions. So important to consider that sepsis or some other cause of decreased SVR could manifest very dramatically. And then the last thing to consider is just contractility. Arrhythmia is something that can be poorly tolerated or very well tolerated, and it depends on what the patient's native function of the heart was before this, and also their RV function. So someone who's got a very bad LV and RV, they may tolerate arrhythmia quite well because the VAD is doing most of the work. In contrast to someone who's got poor RV function, good RV function, and the VAD's only mildly augmenting their LV function, they may present quite dramatically. Similarly, ischemia can lead to decreased ventricular function and lead to arrhythmia. So if we consider non-cardiac causes, in this case, again, it's your standard sort of things you'd think about: stroke, hypoglycemia, rest failure, toxidrome, and there are numerous others. You don't need our help for that. But it's just important to know if they are perfused, you may be left with in a funny realm where you have this pulseless patient who is actually adequately perfused and has some other cause. Um, So if we return back to our case, our patient was successfully defibrillated and we had hemodynamic stability. And what actually happened in their case is they had had a GI bleed, which isn't uncommon in this patient population. They get AVMs, they get von Willebrand factor dysfunction, and they get bleeding. So they bled, and then they became a bit hypovolemic, and there's actually a suck down event in the emergency department, which um, then led to the VF. So they're able to be resuscitated, had minimal downtime, and were actually discharged once they, sort of had management for their GI bleed, uh, uh, you know, on an urgent inpatient basis. Um, Thank you.